I appreciate the opportunity to come again to Saudi Arabia. It's always a pleasure to be here. I thought I would talk a little bit about the historical challenges in congenital heart surgery, how we've overcome some of these challenges, and what possible models we have for the future. Basically, in surgical innovation, we deal with modifications of tools or procedures. Occasionally, we have a revolutionizing procedure or equipment that fundamentally changes how we take care of patients with congenital heart disease. And very rarely, but hopefully frequently in the future, we will have revolutionizing science that will truly change the way we approach congenital heart conditions. Now, if we just look at historical examples of these types of things, the Blalock-Taussig shunt was certainly a revolutionizing procedure in the sense that it began the era of therapy, if you will, for congenital heart disease, certainly cyanotic congenital heart disease. A similar type approach, a new procedure and technique that changed the field, was a non-surgical procedure, if you will, the Rashkin balloon septostomy for transposition of the great arteries. Fundamentally changed how we managed patients with this condition, made very unstable children early after birth into a more stable physiology that then could undergo more elective surgical repair. Now, the Norwood procedure has evolved over the last almost 30 years now as a procedure for one of the more complex fatal congenital heart conditions in newborns. And that was one that evolved over time rather than a revolutionizing procedure that took place over a very short period of time. This had to evolve over several years. The arterial switch procedure, another major change in the way we addressed congenital heart disease, going from an atrial switch operation to a more anatomic arterial switch procedure. I would point out that this transition occurred fairly abruptly, but also at a time when it could be undertaken. When I point out that the mortality rate for an atrial switch operation in the early 1980s was around 3%, the mortality for an arterial switch operation at the same time frame was anywhere from 10 to 20%. It's unlikely that if we went to an IRB today and offered a procedure that had 3 times the operative mortality, we would be allowed even to pursue it. So it just points out that there are times when a persistent approach pays off over time. The balloon valvuloplasty came along as a non-invasive, so-called non-invasive treatment for aortic valve stenosis. It became safe, it was effective, but I would point out that this procedure now may actually be turning back towards the more surgical approach because the long-term outcomes seem to be a little bit better with a surgery approach, and we'll talk about that later. And then neurodevelopmental research has become very important in the field of congenital heart disease as we recognize that the significant majority of children with congenital heart disease have at least some subtle neurological abnormalities that need to be addressed during their lifespan. So what are historical models for surgical progress? Well, the most typical one is what I call the persistence model. Basically, we try, we fail, we try again, we may fail again, but ultimately, over time, as techniques evolve and we gain more experience, we come to success. And a great example of that would be the Norwood procedure or the arterial switch operation, both of which had very, very high mortality early and now have become relatively low mortality operations compared to when they were initiated. Another would be an application of a previous failure to a new problem, and the Blalock-Taussig shunt's a great example of this. The Blalock-Taussig shunt was created with an aortopulmonary connection, but it was actually the result of a failed laboratory experiment trying to create pulmonary hypertension in dogs. And Blalock did a aortopulmonary connection to try to raise pulmonary resistance and found that he couldn't do that because the pulmonary resistance was so low that even with very high flow rates, pulmonary hypertension did not occur. But because of that previous experience in the dog laboratory, when Helen Taussig came to him to talk about the potential for creating an artificial ductus to deal with the problems of cyanosis in tetralogy, he had already performed that procedure in the dog laboratory and was able to bring it to clinical use. Another example would be the hybrid operation for hypoplastic left heart syndrome with banding of the pulmonary arteries and maintaining ductal patency as a way of avoiding neonatal Norwood operations. Pulmonary artery individual banding was actually used first in patients with truncus arteriosus. And individual pulmonary banding was used as a palliative procedure to get these children to an older age in the early days of heart surgery when the technical ability to do complex operations in newborns was not really possible. It was abandoned, and it was abandoned because it was difficult to accurately band individual pulmonary arteries in newborns. And as techniques evolved to do complete repairs in younger age ranges, it no longer became necessary. But it gives a good example of how techniques have been around a long time that may fail, but then come back into clinical use later as things evolve. An idea of a new technology applied to an older idea, well, obviously the Rashkin procedure was a great example of that, a technology to create an atrial septal defect with a catheter. Clearly, before we had the Blaylock-Hanlon approach, we could do an atrial septectomy in a baby without the heart and lung machine, but that was a complex and difficult operation, quite scary actually to do in some cases. And the Rashkin procedure completely supplanted that as the technique for opening the atrial septum in transposition. And then balloon valvuloplasty was another approach to what essentially was dilation in the operating room, either of the pulmonary valve or the aortic valve, and obviously has come into clinical utility. And then there have been new understandings of pathophysiology, including the neurodevelopmental research and the issues related to neurodevelopmental outcomes in children with congenital heart disease. And obviously the most recent field, which is understanding the genetics and the genetic impact of certain kinds of modifications of the genome that do have an impact in outcome related to surgical treatment of congenital heart disease. So where are we now? Well, the mortality is low for almost all congenital heart disease surgery now, but it persists, and the causes of mortality now are often somewhat elusive. It's difficult often to put a finger on the exact cause of mortality after a complex congenital heart repair. Most of our surgical repairs are relatively standardized, and more complex innovative procedures await follow-up analysis. We don't have long-term follow-up on more recent modifications such as the double switch operation for corrected transposition, Nakaido procedures which are coming back into popularity, left ventricular rehabilitation operations for hypoplastic left ventricles, and other sorts of things. And as I mentioned, some accepted procedures are now being called somewhat into question. Balloon valvuloplasty for non-infantile critical aortic stenosis result in more aortic insufficiency, even though they do relieve gradients. But these patients seem to be coming to valve replacement earlier than those patients who have a surgical open valvotomy instead. And there are some centers who have actually shown that the results with surgical valvotomy are better than balloon valvuloplasty, and some centers are now reverting back to a primary surgical approach in older children and young adults. It's also not clear that most mortality correlates with the accuracy of surgical repair, of cardiac repair. And there are some studies being done now to actually look at what lesions at the end of a surgical repair, now that we're pretty routinely doing echo evaluation of our results, lead to additional surgical intervention or to problems with late outcome. But the fundamental problem as surgeons we have right now is that we can sew it together pretty much the same way each time, but the outcomes may be markedly different from one patient to another. And this is a challenge for us to try to figure out why this is the case. I would also argue that most surgical innovations in the future are not likely to be surgical in the strictest sense, that is, development of a new surgical procedure or a modification of a surgical technique. More commonly, the advances in surgery in the future, I think, will be new technologies and new understandings rather than new techniques. We are now in the world of databases and registries, and I question whether databases truly will drive innovation in our field of cardiac surgery. There are pro and con arguments in this regard. Our current databases, and the most extensive one is the Society of Thoracic Surgeons database. There are Congenital Heart Surgeon Society databases, there's a registry of the International Society of Heart and Lung Transplant, etc. They show us what we are doing and what the outcomes of those approaches are, but they don't necessarily tell us what has gone wrong or how to improve. After almost 20 years, there's no obvious demonstrable effect on outcomes or decision makings from the STS database, which has many hundreds of thousands of patients in its registry. Risk stratification has been poor in almost all of the databases, and our population is extremely heterogeneous, especially in the congenital world, where there are over 150 procedures being collected in the STS database in congenital heart disease. It's also very difficult to categorize high risk, what I call sort of one-offs, that is unusual patients that clearly have significant risk, but who don't fall into accepted risk categories, which are really quite limited now in most of the databases that we use. The other thing that most people don't recognize is that the larger the database, the more data you have in the era of big data, the more numbers you have, the more totally random associations will come out of that data. So we have to be careful not to pay a lot of attention to random associations that may not have clinical significance and simply come up from the fact that there is so much data out there that's been collected. The current enthusiasm we have for grading technical performance is somewhat laudable, I guess, but the limitations of echo and poor correlation with early and late outcome are major problems. There are surgeons who can do an AV canal repair in an hour with an excellent result, and there are surgeons who can do the same operation and take 6 hours with the same result. Does that mean there's a quality difference between the two? We can't demonstrate any such quality difference as long as the outcome is the same. And this is why these databases and technical performance and other things can be very limited in our ability to discriminate quality. Quality, outcomes, and risk are the buzzwords now in cardiac surgery and certainly in medicine in general. We're searching for quality indicators, but so far that's been relatively unrewarding, especially in surgery, because we've emphasized outcomes without robust risk stratification, and this can stifle innovation. If we are in a situation where we use mortality as an outcome measure, which unfortunately we do in surgical databases, mortality is no longer a very good indicator of quality, nor is a very good discriminator of quality between institutions, and especially if you don't have extremely good risk adjustment, which we do not have. But if we start comparing outcomes among centers, if we start comparing outcomes and mortality with non-robust risk adjustment, we have the potential to stifle innovation to try a new approach to a standardized problem, because if the outcomes are tracked in such a way without risk adjustment, it may penalize the center that tries to do innovation. Pushing the envelope, that is, taking that extra step, giving a very high-risk patient the chance at a successful surgical result, may now have serious negative consequences for even a well-established congenital heart disease program. A great example of this is the fact that our programs are being ranked. There's a push towards public transparency of outcomes, but these public transparency systems essentially present non-risk adjusted data or data that's poorly risk adjusted, and one or two patients in a center can change its ranking completely, such that we may be giving false information to the public about what true quality is in the congenital heart world. In addition, things like the U.S. News and World Report rankings of centers use very, I would say, marginal quality indicators and risk-adjusted outcomes to essentially rank institutions. But I can tell you that at least in the United States, ranking lists in these kinds of sort of poorly controlled listings has become a major issue for many hospitals, and there is a great push in each individual hospital to constantly improve one's ranking in these somewhat consumer-oriented risks risk-adjusted models. And historical models of innovation progress may no longer be relevant or possible. And as I mentioned, it's very difficult now to advance a new procedure that would be of higher risk initially than an older, less risky procedure. I also point out this frequently because we're all pushing for innovation. Innovation is great. Innovation is a new way of doing something. But it's also important to note that innovation is not always progress. Progress is a new procedure that actually advances the field and improves the life of children with congenital heart disease in this particular case. So here's an example. First stage palliation for hypoplastic left heart syndrome. Turns out that we've known how to palliate this condition since 1968. This was a paper published that showed that the physiology of hypoplastic left heart syndrome could be stabilized by opening up the atrial septum and controlling pulmonary blood flow by individually banding the pulmonary arteries and doing an atrial septectomy. This was 1968. Despite the fact that this was described in the late 1960s, there really, until in about 1970, the very first surgical procedure was done with that principle in mind that was a success for several weeks. This was a child who had aortic atresia, but who had a ductus arteriosus that was maintained patent. It happened to stay open despite not being on prostaglandins, and the surgeons here, Kaler and Associates, banded the pulmonary arteries and did an open atrial septectomy, and this patient lived for over 6 weeks and it eventually died from sepsis. But the principles of palliation of hypoplastic left heart syndrome surgery were already established. And it's interesting that in their paper they said, we consider palliation in selected cases of hypoplasia of the left side of the heart to be indicated, for the current rapid advances in cardiac therapy hold the promise of the development of a curative procedure in the near future. This was 1970. Well, there were many different approaches taken after that. By the late 1970s, surgeons were starting to do connections of the pulmonary artery to the descending aorta and banding the pulmonary artery with an atrial septectomy for hypoplastic left heart syndrome. This is a report by Mori, 4 cases, no survivors by the 1970s. Donald Doty suggested doing everything, including a Fontan in a newborn, to fix hypoplastic left heart syndrome, and no one survived this operative procedure either. Sidlevitsky in 1980 reported a case again of trying to connect the pulmonary artery and descending aorta and band the pulmonary artery for hypoplastic left heart syndrome. Patient did not survive. But this is an example of persistence. And ultimately, by the early 1980s, Bill Norwood, doing essentially the same operation, in this case a right ventricle to descending aorta connection and banding of the pulmonary artery, was able to establish a few successes. Not very many, but a few. By the early 1980s, several modifications were being done, ways to try to limit pulmonary blood flow with a more accurate technique than pulmonary banding, in this case using a flap of pulmonary artery and creating a punch in that flap to limit pulmonary blood flow. And then ultimately, by the early 1980s, Norwood had evolved into an operation that reconstructed the aortic arch rather than trying to bypass it, feeling that he would have better coronary flow with this approach, and using a central and then ultimately a modified Blalock-Taussig shunt to get to what we call the classic Norwood operation, which really was evolved by about 1984. And this operation has gone on to become a successful procedure for hypoplastic left heart syndrome repair. And basically now we have an operation that has a success rate in low-risk patients, that is those over 2.5 kilograms without genetic syndromes, of better than 90%. So we've gone from 100% mortality to about a 10% mortality over about 30 years of modifications of this technique. Now, in neurodevelopmental abnormalities, we've heard passionate declarations at many meetings that you can prevent neurologic injury if you avoid circulatory arrest, use the appropriate blood gas management, maintain a higher hematocrit, maintain tight glucose control, use various types of bypass, techniques, modify the inflammatory response with steroids, etc., make a prenatal diagnosis, perform a neonatal complete repair, palliate in the neonatal period with a complete repair. We've just been searching for that one thing, that one technical thing that will change the neurodevelopmental outcome of our patients. Well, it's turned out that none of those first four have actually turned out to be significant. Prenatal diagnosis doesn't make any difference. And in fact, none of them have actually turned out to have a significant impact on late neurodevelopmental outcome. We've been searching for a surgical fix and ignoring the fact that basically these patients are predisposed to neurodevelopmental abnormalities, and we need to start looking before birth rather than after birth if we're really going to have an impact on this problem. This is what I mentioned, some papers about surgical valvuloplasty versus balloon dilation for congenital aortic stenosis. And you can see in this series the freedom from more than moderate aortic regurgitation was significantly better with a surgical valvotomy versus balloon valvuloplasty. If you look at freedom from reintervention, the surgical patients also were delayed in their surgical reintervention longer than those who had balloon valvuloplasty. And basically the fundamental issue here is it better to have a little residual stenosis than to have regurgitation? And I think most of us would agree that regurgitant lesions are much less tolerated, if you will, than stenotic lesions in terms of overall long-term heart function. Again, another series out of Australia showing that surgical valvotomy for neonatal and infant aortic stenosis achieves better results than catheterization. And as you can see that in their own institution, balloon repairs have pretty much been supplanted now by a reemergence of surgical intervention for this condition, because the freedom from reintervention after surgical repair was significantly better out to 10 years than balloon valvuloplasty for aortic stenosis. Now, how about the role of genetic factors in neurodevelopmental dysfunction? We know that genetics is a very important component of congenital heart disease, but we only can really understand about 60% of congenital heart disease based on known genetic syndromes and genetic mechanisms. But genetic anomalies may include both congenital heart disease and neurodevelopmental dysfunction in the phenotype, so this is a common association. And genetic factors may modify risk of adverse neurodevelopmental outcomes after an injury. So it's not just that you have a congenital heart disease, it's not just that you have a genetic syndrome, but there are certain genetic issues that can modify how you respond to any kind of stress, injury, bypass, heart surgery, etc. Now, genome-wide association studies show that multiple pathways can play a role in complex phenotypes. Many pathways, including inflammation, oxidation, and neural peptides, have an influence on our overall outcome. And there are few successes from candidate gene approaches in complex genetics. We haven't identified specific genes for most congenital heart disease that can be modifiable or approached to change the outcome. Let's see if I can get this. It's not really a hypothesis-driven analysis when you look at genome-wide association studies. It may reveal a role for unsuspected biologic pathways, but often you get a huge sort of plethora of up and down regulated genes, some of which are very hard to associate with anything related to the cardiovascular system. But it is an effective tool to discover disease risk and disease-modifying genes by rapidly screening several 100,000 single nucleotide polypeptide changes, thus reducing the cost. Now, there are a few alleles or SNPs, if you will, that have been associated with outcome after cardiac surgery. And one of these, the candidate SNP selection, identified 6 functional variants, and these particular single nucleotide polymorphisms relate to oxidative stress. And there you can see the various ones here, but they essentially are modified through the superoxide dismutase 2 and CAT pathways, and either result in free radical degeneration or free radical generation or detoxification. Cellular injuries such as surgery can upregulate endothelin, and this can result in poorer surgical outcomes, and also VEGF, which has a role in vascular remodeling. So a study design looked at non-syndromic congenital heart disease subjects and collected prospectively genomes from patients from Children's Hospital of Philadelphia before 6 months of age. And we isolated the DNA. There were 371 survivors followed up. And if you look at the VEGF alpha single nucleotide polymorphism minor allele, it was associated with increase in transplant-free survival. So basically, if you had the good allele, the GG alleles, you had a much better chance of surviving surgery than if you had one of the poorer alleles, such as the AA allele. So one single polymorphism in your genome can give you a 4-fold higher risk of not surviving after cardiac surgery. And again, this is only one of many, many, many genes that we all deal with. So it shows you that there are very subtle changes that can occur with genetic abnormalities. So if you look at transplant-free survival and you use this genetic risk score, 1 to 4 risk alleles, you can see that if you have only one risk allele, you have a relatively low change in your outcome. If you have 2, it's worse. If you have 3, it's worse. And if you have 4, it's significantly worse than it is if you do not have these alleles. The odds ratio being greater than 15-fold risk of death or poor outcome. So what are the new models for the future? Well, we need to have a more centralized, longitudinal follow-up of all congenital heart patients over their lifetime. It is worthless to look at 30-day mortality as an outcome when we're talking about a lifetime for children with congenital heart disease. Critical analysis of new and more complex procedures such as the Nikaido, the double switch, Ebstein's malformation, new repairs, LV remodeling, etc. need to be done because we may be changing the natural history in a negative way for some of these patients with these newer approaches without long follow-up. The double switch being an example. While this is encouraging early on, the results with the double switch for corrected transposition, there are increasing reports coming out of left ventricular dysfunction and problems with rhythm, which require dual chamber pacemaking and dual ventricular pacemaking to try to deal with long-term ventricular dysfunction. And since we're doing these complex repairs in this condition solely to get a systemic left ventricle, it's unclear whether we'll really accomplish a major change in the life expectancy of these children over time. Only time will tell. Simplification of postoperative management and monitoring, I think, is going to be important as outcomes improve. It's very clear that the longer you stay in an ICU, the worse your long-term survival is. And therefore, ways to simplify our approaches to decrease the time that patients are in an intensive care unit under intensive management is important. And then we need to advance genetic testing for applied therapy. We want to use the right procedure for the right patient at the right time, based not only on their anatomy and their physiology, but also on their genetic makeup. So when we look at the future, what should happen and might over the next, say, 10 years? Well, some examples would be regional organ procurement and resuscitation centers. This is already happening. It's no longer a situation where patients are having a heart transplant put in immediately or a lung transplant. In Toronto, for example, lungs are being harvested, sent to a regional procurement center where they're being resuscitated in essentially in an apparatus that perfuses the lungs and allows you to not only make them more suitable for transplant, but you can even genetically modify those lungs by administering viral-induced vectors into the airway to change some of the characteristics of the transplanted organs, and then they're electively transplanted at a later time, usually several days or a week later. This has made an operation that was an emergency in the middle of the night into what is a semi-elective procedure with a modifiable group of organs, and I suspect that the same thing will happen in heart transplantation in the near future. Cellular replacement therapy for ventricular dysfunction is very popular. Obviously, there are many types of stem cell therapies for ventricular dysfunction. Most of them seem to work primarily by adding paracrine factors rather than actually adding myocytes. But this is an area of obviously very intense interest and certainly now being applied to the congenital heart population. We need pediatric destination cardiac replacement devices, just as has been evolved in the adult population, and this is coming. Patients, especially with the Fontan circulation, may need to have a destination artificial heart, and there are other significant changes in the way we look at assist devices for the single ventricle population that are coming down the road. Tissue-engineered patches, conduits, and valves are also very important. We haven't really had these come to fruition yet, except in some essentially vascular tube-type models in Japan, for example. But there's great potential for us to have tissue-engineered conduits and valves that may limit the problems we have with children outgrowing or having deterioration of conduits and things used in cardiac repair. And ultimately, use of genetic testing to drive modifications of care, I think, will come in our lifetime, certainly. But what shouldn't happen but will or has? And I would argue that the use of mortality databases to compare center outcomes without robust risk stratification has happened, it's continuing, and it will probably cause a great deal of conflict and disruption in our field. The use of short-term outcomes as a quality measure, I think, is probably not appropriate. And we're still struggling to find true quality measures. In many of our hospitals in the United States, the hospitals monitor the incidence of infection of central lines as a quality measure. It's percent of line days that have an infection is used as the quality index. The problem with it is it totally ignores the denominator and the practice of the institution. So if an institution doesn't put many central lines in or takes them out very quickly, they will, by default, have a higher incidence of line infection. And centers that put a lot of lines in for a short period of time will increase the denominator and have a lower incidence. It's not a true quality measure. It doesn't really measure process, and it doesn't really measure quality. Arbitrary assignment of complications as quality measure, again, ignoring the denominator, is a problem also. And the use of random cluster events to evaluate surgical programs and surgeons is also an issue. Measurement of technical outcomes with flawed imaging modalities is also a concern. We've been using transesophageal echo to monitor our heart repairs for years, but I can tell you that many times, and in certain lesions, this is very inaccurate, especially pulmonary vein evaluation after vein repair, and grading the magnitude of regurgitation and the magnitude of residual shunts is very difficult by echo. And ultimately, the use of social media to drive clinical decision making. We are now constantly being bombarded by social media and the implications of this. I can't tell you how many of my families with congenital heart disease already have a website before they ever have a surgical intervention on their child. So what are new models of progress? I think the adoption of new technologies will make cardiac surgery look less and less truly surgical in the traditional sense. Innovation is desirable as long as it's progress. That is, it's safe and effective, but it's also superior to previous techniques. And understanding the causes of poor outcomes will be much more important than simply tabulating them in registries and databases. It will be increasingly important to collect long-term data on older and newer techniques to provide comparative effectiveness data to guide our patients' choices. Thank you.